Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Today I'm happy to report to you consensus has been reached. I'm going to discuss with you a very important document that's come together as it relates to antiplatelet agents and gastrointestinal injury. Now, this document was put together in collaboration between three societies: the American College of Cardiology, the American College of Gastroenterology, and the American Heart Association. Recognizably, the use of antiplatelet agents has expanded ever since the 1990s, when it was estimated that nearly 70% of people over the age of 65 were taking NSAIDs, at least on a weekly basis. Over 34% were taking aspirin on a daily basis. Now think of what's happened since then. The expanded use of stents, the routine use of aspirin and Plavix. These drugs are certainly capable of keeping stents open, but also incurring GI injury. To that end, the groups came together with some guidance that will be very pragmatic as it relates to primary care, gastroenterologists, and cardiologists to come to some guidance as to what we should be actually doing. Now, the first was looking at the data as it relates to aspirin and combined with an arthritis medicine, another NSAID, COX-1 and COX-2 non-selective inhibitor, or even a COX-2 selective inhibitor. The recommendation is absolutely these people should be on a proton pump inhibitor as a prophylaxis agent because their combination risk is significant for GI injury. Now, the second recommendation is what relates to cardiac aspirin, and recognize that cardiac aspirin increases the risk of GI injury nearly 2 to 4 times, and prophylaxis should be individualized based on their other relative risks. So somebody on multiple NSAIDs, high-dose NSAIDs, age over the age of 65 to 70, people with previous ulcer complications, previous ulcer disease, those patients on steroids or anticoagulants should all be considered as very high-risk patients, and even with cardiac aspirin on board, prophylaxis for GI injury should be recommended. The third is as it relates to patients on the use of Plavix or Clopidogrel. This is an agent that is frequently viewed as a default if patients come in with an ulcer bleed on aspirin. And it's recognized now that Clopidogrel in and of itself has significant GI potential risk. We know that this agent interferes with epidermal growth factor release and angiogenesis, both prime reasons for why patients may have complications for an erosion developing into a more significant complication like an ulcer and a bleed. So the recommendation was to not switch people that come in with aspirin and a GI complication to Clopidogrel as a safe harbor. In fact, the data is that patients on a proton pump inhibitor and aspirin do far better than Clopidogrel by itself, and there are observational studies now that show the Clopidogrel risk is diminished with a proton pump inhibitor. There are now prospective randomized trials with Clopidogrel and a proton pump inhibitor, so more to follow. But present day, beware of Plavix or Clopidogrel by itself without significant GI concern. The fourth issue is it relates to patients on anticoagulants, warfarin, in combination with an aspirin or Clopidogrel Plavix. These patients categorically should be put on a combined prophylaxis regimen with GI injury concerns. Now, I've said a lot about prophylaxis, but the group also recommended that it's recognized that the best prophylaxis is a proton pump inhibitor. So when we talk about GI strategies here, we are talking about proton pump inhibitor as the preferred strategy. Another area of concern was as it relates to H. pylori. So anybody that has a previous history of ulcer should be considered and screened for H. pylori and treated if positive, in fact, if they have a previous history of ulcer before beginning antiplatelet therapy. Now, if you see a patient in your office that comes in on antiplatelet therapy with that history, it's natural to go ahead and make that recommendation and screen for H. pylori and treat if positive. What we're also recommending in this guidance is that the patients don't always need to stop their dual therapy or their antiplatelet therapy. Aspirin and Plavix in and of themselves have significant risk. But when they come in with a GI bleed, it's a close dialogue between the cardiologist and the gastroenterologist, because there's ever increasing evidence that as one group stops their medications, their antiplatelet agents, there may be a significant greater risk, for example, thrombosis or potential complications of a discontinuance of the antiplatelet agent. So the gastroenterologist and the cardiologist need a dialogue, and stopping these agents blindly is not simple and not certainly the recommendation of this group. It should require careful clinical judgment, weighing off the potential risk both for rebleed versus thrombotic events. That's the guidance that this group came together. It's the first time we've seen dialogue between the cardiologist and the gastroenterologist. We've all viewed this in our own blind men and the elephant syndrome, where we're seeing one side of the elephant and saying, don't take antiplatelet agents, don't take these therapies because they're toxic. Cardiologists say, we need these to keep stent patency alive, and this is certainly that the primary care doc sees as they come through their clinics routinely. We need to have better dialogue. So the good news is the consensus is the consensus is in. The bad news is the consensus isn't out yet, and we need to apply these now to clinical patients to really make them really viable alternatives or viable impacts on patient care. Hopefully we've spurred some interest in this, and I would encourage you to select this, discuss this module that you can connect with your colleagues and dialogue. I'll look forward to the discussion with you again. Dr. David Johnson, have a good day.